When I talk about meaningful use, I like to start off with a big picture. And the best way to start off with a big picture is to show a few pictures. When I first got to ONC, we were in Washington, D.C. We don't get a lot of snow, maybe a little more than Seattle, but not a huge amount. But the winter of 2009, 2010 was what in Washington was known as Snowmageddon. And we had pretty enormous snowstorm. Anyway, so we thought about different meaningful uses of snow, such as the snowman. We moved on to spring, and of course things start to grow. You get grass. I am from, Sam and I were talking, Brookline, Massachusetts, and the most meaningful use of grass that I could think of was the beautiful Fenway Park. And then, of course, in Washington, you move on to summertime. And in summertime, you get these huge thunderstorms. And the thunderstorms produce this mud. And what happens actually is there's this mathematical equation. You take meaningful use, MU, you multiply it by dirt. The product of that equation looks something like this. Now, there may be a question now, what in the world are all these pictures about? And the pictures are to demonstrate as clearly as I possibly can that meaningful use of EHRs is not about technology. It is about what you do with the technology to improve the quality, safety, and efficiency of care. Now, in Washington, D.C., and outside of Washington, D.C., the phrase Congress and its infinite wisdom is usually meant sarcastically. In this case, when Congress passed the high-tech legislation, which was part of the American Recovery and Reinvestment Act, ARA was also known as the stimulus bill. When that was passed, they actually made this important piece of the legislation. They said, we are not going to pay hospitals and providers for doing the same bad processes faster. This is not about electronifying information. This isn't about turning paper charts into digital versions of those paper charts. It's about changing processes of care to improve quality, safety, and efficiency. So what I'm going to do is talk about 4 fundamental questions. So the first one really is, do EHRs matter? And I know with a few people here, I'm going to have the opportunity to talk about this in the journal club later and some articles that come out, and we can, I'm very interested in engaging in more discussion. But does health IT make a difference? If it does, how and why? What are the ways it affects key health outcomes? What is in meaningful use? So what is in stage 1 meaningful use? What was included in stage 2 meaningful use? And actually a little bit about what may be coming down the road for stage 3 meaningful use. And then finally, how does meaningful use serve to help to facilitate transformed care delivery? How does it help achieve better population health? Not achieve, but provide a platform for that achievement. So this is an article that appeared in Health Affairs a couple years ago, and it basically tried to summarize the literature. There are certainly studies that show that EHRs don't have an effect. There are some that show even that when implemented incorrectly, it can have a negative effect. But the vast majority of the literature does show a positive effect, and that is around quality and cost and provider satisfaction, and when implemented with patient-facing technologies, patient satisfaction as well. Now, I think there's a really important piece with this literature, which is that all of this literature was conducted prior to the meaningful use framework. And in fact, virtually everything that's still coming out is really before meaningful use was really embedded in care delivery. And so that means a couple things. First, it means that most of these studies aren't talking about a real comprehensive approach to the meaningful use of EHRs. In fact, many of these studies are actually looking at specific elements. So they might look at CPOE, computerized physician order entry, or electronic prescribing, or some particular element of digitized electronic information for health information, for healthcare. And so what it really is, it's a caveat, it's just to say that I think we will know more in the future as we see studies that actually document the full implementation of meaningful use, and in fact, as we move through the different stages of them. So let me share with you one study. This was a New England Journal study that came out last year from some research done in Cleveland. And they basically looked at delivery systems where EHRs were used versus systems which were using paper chart. And there are three things that kind of stood out to me about this study. The first is, you can see on the left side just tremendous difference. Now the percentages here are what percent of patients got all of the recommended key processes of care for diabetes. So that's part of why the numbers are low there. But you can see there's a big difference, 51% to 7% got all of those things, EHRs versus non-EHRs. Now, of course, the other thing is 51%. Not very easy. So we got a long way to go. Whether or not you're using an EHR, care is clearly suboptimal, and there is a lot of room for improvement, and I think that's really important. There's one other piece of this research that I think is really important to consider. When you look at some of these other outcome measures that they track, and outcomes here really maybe more intermediate outcomes in some cases. So it's, did they actually control cholesterol? Did they actually control HbA1c and blood pressure and so forth? You can see that the impacts on these intermediate outcome measures are not as strong with the EHRs, and the differences between EHRs and paper charts not as strong as the process measures, and it might raise a question why. Now, part of it, very importantly, is that in this study, and this gets to again, what are these studies measuring? The EHRs that were being used made very little use of patient-facing technology. In order to control blood pressure, control cholesterol, certainly in order to reduce obesity, you've got to figure out ways to use the technology to help you to engage patients and families in their care. And you can see with BMI, for example, there was no difference in this case. So let me just give you a case study. This is Dr. Chris Tushin. He's a family practice doc in the cornfields of Wisconsin, about an hour from Minneapolis, St. Paul. And he practices kind of out in the middle of nowhere, very small practice. And this is a slide that he shared with me. And what he said to me was, there were things that the EHR allowed me to do that I wouldn't have been able to do, that I wouldn't have been able to have done. If I, in the course of my busy practice, kind of get all the patients in and see everybody, there's no way I would have been able to do this. There was some new contraindications that came out on statins, and he had, of course, hundreds of patients on statins. And what he was able to do was then to just run a list of all his patients who were on these statins. He didn't have to go chart by chart, and was able to address that and then potentially prevent some contraindications based on the new literature. And that's something he was able to do right away. So the question is, so we've got Dr. Tushin, but what about, whether is it having an impact beyond that? And I think clearly the growth in the use of EHRs is dramatic. If you look in sort of the history of the use of EHRs in the last 20, 30, 40 years, it got up to, in primary care practices, about 20%. You can see in hospitals, by 2009, it was at 16% when the high-tech legislation that encouraged meaningful use was passed. And that has basically doubled in the course of the last 2 years. This was actually 2011 data. 40% of primary care physicians by 2011 were already adopting EHRs, and we are now at a point where probably, as we approach 2013, about to move over the tipping point of 50%. And when you ask hospitals what are their plans, you can see 85% are planning to attest within the next 2 or 3 years. They haven't already. And that has led to a lot of money being paid out for this. right? Over $8 billion have been paid to 166,000 providers treating Medicare and Medicaid beneficiaries. This chart is just an example of the Medicare payment structure. And one thing I will just say is that when you see the green, blue, and orange boxes there, the ones, the twos, the threes, those are the stages of meaningful use. And importantly, stage 1 meaningful use was designed to try to get as many providers as possible onto this escalator and create a certain set of basic expectations around EHR usage. Stage 2 is trying to incorporate more advanced care processes in order to get us further to where we want to go around actually improving outcomes in stage 3. So there is this understanding that it's going to take a little while to get to where we want to be. So why and how does this affect things? And I think there are different ways of looking at it. I'll take this one approach. Looking at the bottom of the slide first, there's a certain electronic information infrastructure that we are trying to create. If you have providers and patients meaningfully using electronic health records in the context of the clinical delivery of care, that's sort of the first part of it. But that information needs to go beyond the walls of that clinic or that hospital. For that, we have got to have robust health information exchange. And then what happens then is you have a certain amount of data liquidity. You have the ability for data collected in one setting to be used to help manage care across the continuum of care. And really, the idea here is that we are creating, over time, this basic electronic information infrastructure. With that in place, there is the ability to then begin to advance certain key clinical processes. And just a couple of examples: care coordination, electronic clinical quality measurement, and by getting those clinical processes in place, then we can achieve some better outcomes through pairing providers, improving quality, et cetera. Everything I was talking about was related to the Recovery Act and the high-tech portion of it. Of course, that in some ways laid a foundation for healthcare reform. And one of the elements of the Patient Protection and Affordable Care Act, or ACA, the health reform law, was that it created this expectation of a national quality strategy. Now, there have been a lot of different kinds of quality strategies thought about and discussed in the past. What happened here is that the Department of Health and Human Services took this as an opportunity to try to create great focus. And some of the leadership at HHS really said, there are many, many important things in health, but for national priorities, we need to create some very tightly focused initiatives in order to drive forward clinical care delivery. And specifically, they said there are, with all the things that we want to do, if we say that we're going to do all of these things, we're going to have 20, 30, 40, however many priorities, that's just too many focus areas. And you give people too many focus areas and you can't get focus on the most important thing. So there were these 6 priorities. The first one, make care safer. Second, make it more affordable. Third, improve effective communication and coordination of care. The fourth was around creating an opportunity for the widespread use of best practices that encourage healthy living. The fifth one here is around promoting the most effective prevention and treatment practices, specifically starting with cardiovascular disease. Now, there are obviously a lot of important conditions, but the department said, we know what the greatest killer of, ingredient in mortality and morbidity in this country is. It's cardiovascular and cerebrovascular disease. There's going to be a focus on that. And then finally, ensuring that each person and their family are engaged as partners in their care. And those 6 priorities then are importantly guiding all of the quality initiatives throughout the entire department, whether they be related to the health reform law or to anything else. And as you'll see, very much related to meaningful use. So I'm going to actually walk through 4 of those priorities in talking about stage 1 and stage 2 meaningful use. Now, sometimes people look at the list of objectives in meaningful use, 25 objectives for eligible professionals in stage 1, 24 for hospitals, and they say, oh, this is a long checklist. But it's not a checklist. It's a set of objectives that are tied very tightly to the national quality strategy. So first of all, you need to have certain data. You need to have that data in a structured form, right? Demographics, blood pressure, problem list, medication list, structured laboratory data. All of that data in a structured form is important for a lot of the things that we want to do in improving quality, safety, and efficiency of care. So as an example, we need to have structured data if we want to do robust electronic clinical quality measurement. If we want to get away from every time we want to measure clinical care from pulling charts and reviewing charts, we need to create structured data that we can use for that purpose. CDSS clinical decision support systems, making sure that we have alerts and reminders that help to guide clinicians and, in some cases, clinicians and patients in their care. And registries, right? Not just focusing on, not being just reactive, but actually staying proactive. And this is, again, how Dr. Tashin went about his approach for dealing with these contraindications on statins that came out. Having a registry of all his patients who needed cholesterol management. There was an initiative launched, I guess about 2 years now, called the Partnership for Patients, and this had 2 very clear goals in terms of improving patient safety and reducing errors. The first was to reduce hospital-acquired conditions by 40% and to reduce readmissions by 20%. And so, again, what is the electronic information infrastructure that will help support safer care? So take the things that we already talked about. Actually, some of those were already up there too. And then we add in things like allergies. And then we add in some key processes. We say, well, we're going to try to get automated ways of entering orders. We're going to ensure that there are drug-drug and drug allergy interactions that are populated in the EHR. And electronic prescribing to reduce prescription errors. All those things can have an impact on safer care. And those were all stage 1. And then in stage 2, electronic medication administration record, or EMAR, was added as an expectation on the inpatient side. We want to know what's the, make sure that that the right patient gets the right drug in the right dose at the right time. And by using things like barcode technology, we can make sure that those kinds of errors don't occur in the inpatient setting as well. So once we have those things in place, then we think a little bit about how we're going to use technology to engage patients and families. So we know that, for example, 40 to 80% of everything that a patient hears in the doctor's office is completely forgotten by the time he or she gets home. And in fact, about 50% of what they remember is actually incorrect. So we want to ensure that, and it's not the fault of providers. Primary care providers, for example, they've got 16 minutes on average for a patient visit. Some people say that's actually more than they usually have. But on average, most of the data I saw said about 16 minutes, and on average they cover 6 topics. That's 2 minutes and 40 seconds per topic per visit. That's a lot of information for a patient. And one of the ways that we can help ensure that patients really can do something after the visit based on what happened during the visit is to put it on a piece of paper or send it electronically and then link it to some patient-specific education resources that help follow up on that. And then patient reminders for preventive and follow-up care. And then ensuring that patients can get access to their data so that they can look at it both whether they want to see it in print or online. And in stage 2, there was a change in that paradigm. The expectation is not just that they can have that the information is available, but they can actually view, download, and transmit it. And actually, what's not included here, but at least as important, is a changing expectation of what providers are expected to do with regard to patient. In stage 2, it's not just enough to say the information is available. You can find it, you can go get it. Providers are actually going to be held accountable at a very low threshold initially. But they're going to be held accountable for actually patients accessing that information, using that information, and sending them secure email. Now, some people say, well, my patients, they don't want to use this technology, or it's hard to get them to do that. Well, we can make the same argument about controlling blood pressure, controlling cholesterol, or HbA1c. Now, we're moving from a point where we're moving from structural and process measures to more outcome-oriented measures. And there's a level of accountability that providers are going to be expected to be held accountable. And that's part of true patient-family engagement, is making sure that providers actually play a role in engagement. So the last, the 4 NQS priorities that I'll mention is more coordinated care. So we take all the things we had already, and then we add medication reconciliation and sharing a care summary, so transitions of care or referrals of care. And in stage 2, that really expanded to be a much more standards-based transitions of care summary, and importantly, it actually needed to be used to transfer from one setting to another, from one delivery system to another. It had to be able, it's going to have to be able to go both across providers and across vendors. And it's very important to move from kind of where we've been in the past, where we've had these sort of walled gardens of information, where we couldn't get information out of silos from one delivery system and move them to another. So I've already talked about it. When we released last March the notice of proposed rulemaking, this is what I tweeted. There were just a few key principles. And many of them we've already talked about: health information exchange, patient-centeredness, national quality strategy, flexibility for providers, and alignment of the measures that are being used. We talked a little bit about this before. Let me just talk about some of the important changes that were made. There was some extra time given to implement. There was that slope I mentioned there. You can think of the slope of a line, right? It's the rise over the run, and if you're trying to figure out how to make things work in the context of people feeling challenged by trying to meet certain expectations, you can either reduce your expectations, reduce the rise of the curve, or you can extend the run, extend the time. And what HHS decided to do was the latter, basically saying, we really thought it was incredibly important that we do these things around health information exchange and more coordinated care, et cetera. And if it meant that giving providers an extra year was important to make that happen, so be it. Stage, as we move towards 2015, we will no longer be talking just about incentives. There will be sticks as well as carrots beginning in 2015. Providers that are not meaningful users will begin that are treating Medicare beneficiaries on the Medicaid side. But those providers treating Medicare beneficiaries will see declines in their reimbursement if they are not meaningful users actually by 2014. And those penalties will kick in 2015, beginning at 1%, going up to 2% in 2016, 3% in 2017. Depending on the level of adoption, it could conceivably, by 2019, get up to 5%. But the point is that there's incentives up front, and there are penalties on the back end. I sort of talked about this issue of real interoperability, moving past just the test case, the issue of provider accountability, and I talked about this new core objectives already, so let me just move on to some issues around the clinical quality measures. One of the things that I was talking about, the issue of structured data and how important that is for clinical quality measure. I was, in the 1990s, I was at NCQA as the director of measure developing these HEDIS measures. We're making big strides in actually including, moving from where we just had preventive care measures like mammography and pap smears to measures of actual chronic care management and intermediate outcome measures, blood pressure control, LDL control, et cetera. But it still was, in many cases, requiring a lot of chart review, and it required a lot of, and even within that, there are things that we couldn't do. So, if we think about the issue of blood pressure control, we know that if our national quality strategy objective priority is to reduce morbidity, mortality associated with cardiovascular and cerebrovascular disease, we know that the people at most risk are the people who are most out of control. So getting a patient from 160 to 141, for example, has a much bigger impact on morbidity and mortality than getting them from 141 to 135. But the current measures are rewarding the latter but not the former, right? And that's not really going to, overall, I think it can help us achieve our goal by giving people generally the incentive to try to control blood pressure. But really what we want to be doing is to be giving credit for that improvement. And so with stage 2 meaningful use, there is now a measure that has a longitudinal blood pressure improvement assessment. And it looks at the actual improvement rather than looking at this sort of binary yes-no control. Over time, there will clearly be many more patient-reported outcome measures, and there are a few functional status measures in stage 2 meaningful use that providers can select around hip and knee replacement and care for patients with chronic conditions. There's a real dearth of care coordination measures, and this is one of the things that clearly plagues our delivery system. And there are a lot of ways we might talk about actually, what are the ways to really drive improved care coordination that might not be just through quality measures, but it is something that the department is working very hard at doing. And there is this example of closing the referral loop as a new measure that's included. And then patient safety measures. And I think I'll talk in a few minutes about some of the specific challenges around patient safety measures related to perverse incentives. But there are a few new measures around high-risk drugs in the elderly, adverse drug events, and falls screening that try to get at some of the measures that we want to be using in the future. I'll just say, I won't go through all of these because some of them I've really discussed already, where I wrote thresholds. There's a lot of debate about, well, should the CPOE be at 30% or 40% or 60%? What we found is that it doesn't actually make sense. So CPOE in stage 1 meaningful use was at 30%, but of the people who are reporting data to CMS, the average CPOE percentage is around 85 to 90%. Once people are doing it, they're moving forward, they're not going back. In some cases what you have is a hospital will be implementing it on a unit-by-unit basis or something like that, and so that sort of makes sense that you might give them some. And that was sort of the idea behind EMAR, was that at least start off with 1 unit and get up to 10%, that kind of thing. The other thing I wanted to make a point, because I mentioned in the tweet, I said something about alignment and reducing redundancy, and there has been a lot of redundancy, both within the department in terms of the quality measure, but also across, between the public and the private sector. And the requirements on providers for producing multiple types and multiple forms of, in some cases, the same measure has created a lot of pain among providers, because there's no reason for that. Well, there are reasons, but not good ones. And so one of the things that's really happening is that a real concerted effort to align the measures among the different programs in CMS, and then work with the private sector, payers, purchasers, and others in the private sector to try to ensure that those pay-for-performance programs that they're implementing, or that states are implementing for their Medicaid programs, for example, are also using the same measure. See if I can get this. Maybe not. All right, we will move on. So as far as Amash Tashari, my old boss, really was describing the blogosphere as having this rant on walled garden. But this really gets back to the issue that data needs to flow. It needs to be, when someone is moving from one facility to another, being discharged, being transferred, you need to be able to get that information from one silo to another place. And having that information that can't be moved either between providers or between providers with different vendors is a big problem. So let me say a few words about stage 3 meaningful use, which won't be out for another couple of years, but the Health IT Policy Committee, and this is an independent committee that advises HHS. It's a fully open, transparent committee. Any of you who want to can either go to or log into their monthly meetings. They also have work groups that meet, meaningful use work groups and quality measurement work groups and all kinds of work groups. Between the Health IT Policy Committee and the Health IT Standards Committee and all of their work groups, they have averaged a meeting or a conference call, all open to the public, every other day for the last 3 years. So there is a lot of opportunity for input. Every single one of them ends with an opportunity for public comment, and all of that has generated a really important inclusion of information from the public. So they have released a request for comment, which is now out, and all of you should look at it if you're interested and send in your comments. The comments, I used to read literally thousands of comments, and I can tell you that they had a big impact on the direction of the regulations. But they have released a request for comment related to proposed measures for and objectives for stage 3 meaningful use. And the idea behind doing it this early is to give the industry as much lead time to start thinking about it, both for vendors to think about the kinds of things that they're going to have to program, but to make it a smarter process, but also for providers as they think about how they are trying to manage population health, help think about what is a roadmap of things that can be done to help improve care delivery. So these are some of the things, enhanced clinical decision support, obviously very important, tying that clinical decision support to specific clinical quality measurement priority areas. Patient-oriented dashboards, trying to think about how to incorporate into the clinical workflow information about specific patients in a way that clinicians can really use. There's a big problem with the lack of follow-up of abnormal test results. People die frequently because abnormal test results are just not communicated. And there is a real opportunity to use technology to make sure that doesn't happen. Adverse event reporting, both for general adverse events, but also thinking about HIT system safety itself and how to make sure that as new health information technology is being implemented, that it doesn't, in the process, create new safety problems. And that's something that is being proposed for future stages of meaningful use. And we also know that one of the people who has a lot of knowledge about what's happening with a patient is the patient him or herself. And this proposal is about patient ability to request corrections to the record. It's not that they can go in and they can go and change stuff themselves. It's that if they see errors, they can let the providers know, and that can go through a process to correct the error. Only one person knows who is actually taking current medication. That's the patient or the patient's family. And that may be because they're over-the-counter medications or herbal medicines, or because they just inactive, or they just, hey, I didn't like the way I felt when I took that medicine, and I'm not taking it anymore. And when you ask the patient to look at that, you can really learn things. So there are important things that will be coming down the road, probably with respect to patient and family engagement, creating opportunities for automated, preset, designated entities to receive information about patients, The incorporation of patient-generated data. Obviously, patient-reported quality measures is an important piece of that, but there are many other things that can be collected from patients that can really help to guide safer and more effective and higher quality care. And trying to make the information that patients receive more specific to their particular language or culture, and more specific to their individual needs at the particular time of the visit. And over time, the summary of care record will certainly be expanded and will include more things, and there will be greater expectations of how that information is shared and what is done with it, so that things like, so that you can actually close information loops in the process. So let's just move on and talk a little bit about how it can be used in the support of transforming care delivery and better population health management. Whoops. So I'm going to move through some of these. But let me talk a little bit about this. This was a JAMA piece that I published with some other people while I was at NCQA about a dozen years ago, actually. And in it, this was at the time I was working on a development that was actually just published, a new LDL control. There was a huge debate over what the threshold should be. Ultimately, it was a 130 rather than a 100. And the debate really, and so we were working very collaboratively with what you might call very, some call them the public health zealots or the cholesterol mafia. They were people who absolutely believed that we needed to improve management of cholesterol as aggressively as possible because there's a strong evidence base for it, and they were intent on doing it, and we absolutely agreed with that in principle. But there really are two different purposes in it. PEDAS, the health plan employer data information set that NCQA uses to measure health plans, is an accountability instrument. And pay for performance programs for private payers and now CMS, Centers for Medicare and Medicaid Services, actually change payment based on it. There was a real concern that a lack of flexibility with a specific measurement might create perverse incentives. And you might create a situation where if you have a patient whose risk factors, are sort of borderline, and you're trying to decide if they're at 103, if it's really worth, and they're maybe having some negative reactions to when you're increasing the dose on their statin, is it really worth pushing them higher in that dose just to get them to 99? And I think that that was really part of the discussion. That really is a conversation that a clinician should have with the patient and make a decision together about what's right for that patient in that particular case. Now, as a quality improvement goal, there's no doubt. So a measure that's being used for the purposes of driving internal quality improvement, well, there was no doubt that measure would have been 100. But for the purposes of an accountability measure that's going to change payment and perhaps drive people to do things that might not be what that patient wishes at that particular time, the feeling was 130. Now, I mentioned before about patient safety measures. There's some real safety issues involved here when you're thinking about designing patient safety. You create adverse drug event measures, for example. You have to be really careful that you are not basically promoting people to hide their adverse drug events, right? What you really want to do is you want to make sure that there is an incentive for them to report them and to use that information to improve. And that's where we have a real challenge in balancing those competing priorities. We want to hold providers accountable for safety, but we have to be careful about those measures actually driving things that do the opposite. In the interest of time, I'm just going to move forward. So just going back to Dr. Toshin, what he said to me about meaningful use was that it actually provided a roadmap for him. Like he doesn't have the benefit of a huge IT department at the University of Washington and things like that. he is just a little private practice doc in rural Wisconsin. He said, you know what? When I first saw the list of these 25 things, it was a little bit overwhelming, but actually when I looked at each one of those, it sort of ended up in the same place as what I was showing with the National Quality Strategy. Each one of those objectives actually resonate. We realized each one of these is going to help me to deliver better care to my patients. And that's what happened. And the other thing that happened is, there were a couple of, when he was first looking into this, he didn't implement the EHR until after the stimulus bill passed. But when he was looking at it before then, and there were a couple of things that he wanted to do that the vendors didn't provide. And after the expectations were changed on the vendor side, that meant that any certified EHR he chose was going to do these functions. And we can have discussions about the usability and how well those are being done. But every certified product could produce, in his case, he really wanted his patients to leave with that after visit summary. And before, that wasn't happening. He actually took that money and then he reinvested it immediately. He got his $18,000 for Medicare. And he then said, okay, I'm going to put some color printers in each of my offices so that I can print out information for my patients at the time of the visit. He moved forward on things that actually aren't requirements until stage 2 around patient portals. And then he actually made some really big improvements in his diabetes performance, such that through his health partners and Blue Cross Blue Shield that had these pay-for-performance programs, he went from being a decent provider to being one of the highest providers and got some bonus payments for that. And then he said, you know what? I am now confident that I have the tools and the infrastructure I need to accept risk for my population. And a year ago, he signed his first total cost of care contract. And is actually doing that this year, I believe, with 2 more payers, so that a majority of his commercial insurance is now basically accepting population risk for the entire population. So I'm just going to share a quick story of my own experience. This person on the right is my dad, and the other is my mom. About 2 years ago, my dad wound up in the ICU at Beth Israel in Boston. I was 500 miles away, and it was totally unexpected. He ended up with sepsis. And they actually never figured out why. But what was remarkable, though, is because my mom wanted me to have access, so she gave permission, I was able to access all his information, all his data through something called Patient Site at BI. And because of that, I was able to follow along every test and every vital sign that was taken, I could see in the chart almost in real time. And some of the information wasn't explained as well as it could be. But what it allowed me to do was to have conversations with his doctors and his nurses and be able to keep track of what was going on. Now, whether or not that had a direct impact on quality and safety in his particular case, I don't know that it did. In fact, I don't think it did. I think they managed to care well, and most of the questions I asked, I got perfectly useful answers. And when I was asking about, I knew he was on Coumadin and for AFib and wanted to make sure they were aware of that and things like that. So it turned out that it probably didn't have a big quality and safety impact, but it had a huge effect on me and a huge effect on my mom. And I think it's important that we keep those things in mind. So I'm going to close and then open up for discussion just by saying that I know a number of you are working and trying to achieve meeting these. And many of the toughest experiences in life, I know, are also some of the most rewarding. And so my final picture is these running shoes and making meaningful use of those running shoes.